see better. So I'm Liana, and I'm so glad you could be here today to listen to this talk on diagnosing pediatric cancers for the primary care provider as part of Childhood Cancer Awareness Month. I was interested in giving this talk today because for most of our pediatric oncology patients, really their cancer journey starts with their pediatrician. And so it's so important that pediatricians feel comfortable with the initial workup for when you suspect a patient might have cancer. That brings us to our learning objectives. My hope is that by the end of this talk, you should be able to discuss the differential diagnosis and initial workup when there is a concern for a new oncology diagnosis, and also understand the indications for specialized care. I also wanted to acknowledge the knowledge gap that can make this challenging to do. I believe that pediatricians really have the hardest role in identifying the pediatric patients who might have cancer. And fortunately, childhood cancers are rare, but they have diverse presenting signs and symptoms that make them difficult to diagnose. Many of these symptoms, such as fevers, fatigue, pain, and enlarged lymph nodes, are nonspecific and have other much more common causes. And that can make it difficult to distinguish if the symptoms and signs warrant including cancer as a differential diagnosis, and whether you really need to have this child get additional workup. Certainly as an oncologist, the majority of the patients I see in consultation were referred to me because they have significant symptoms or test results that put cancer high in the differential diagnosis. But as a pediatrician, you have to be ready to pick out those rare patients whose enlarged lymph nodes really are cancer instead of infection, or whose bone pain is due to a tumor and not just a sports injury. And so that can really be a challenge. And so the goal of today is not to make you more anxious and start ordering a lot of additional testing to make sure you're not missing a cancer diagnosis in an otherwise well patient, but really it's to prime you to know what questions to ask and what tests to get when you do have a patient and you're worried that they might have cancer. Here's the outline and what we're going to cover today: epidemiology of childhood cancer, the importance of reducing diagnostic delay. We're going to review some cases, talk about predisposition syndromes, and then also review oncologic emergencies. So let's start off with epidemiology of childhood cancer. Just how rare is pediatric cancer? There are approximately 10 to 15,000 new oncology diagnoses in children and adolescents in the US every year, about 10,000 in the 14 and under range, and 5,000 in the 15 to 19-year-old range. And even though it's a small number of patients who get cancer, unfortunately, cancer accounts for about 10% of childhood deaths and is second only to accidents as a cause of death in US children. So even though it is rare, it has a big impact on child mortality, which is why we're always working to improve treatments and outcomes. And here you can just see the breakdown of which cancers we see in different age groups. Certainly in the under 14 children, leukemia is the leading diagnosis at 31%, followed by brain tumors and then lymphoma. In teenagers, we start to see more epithelial cancers, as well as brain tumors, lymphomas, and leukemias. So I think just keeping, what the most common oncology diagnoses in mind are can also be helpful when you're trying to figure out a patient. So why do we want to, streamline getting the right diagnosis for these patients? I think it all starts with trying to minimize acute complications and get the right diagnosis so we can start treatment, and also therefore decrease the risk of long-term sequelae. Certainly, if we have a smaller tumor burden at diagnosis, sometimes patients require less treatment, and therefore they can have improved outcomes. And I think also such a big part of this is communicating with families. And, I think sometimes just because diagnosis is not clear, there is some back and forth and parents waiting to try to figure out what's wrong with their child. And as much as we can reduce delays, I can think that can also help facilitate trust in the healthcare system. So what are things that can lead to some of these diagnostic delays from a patient standpoint? There was one study that looked at risk factors for prolonged time to diagnosis. And one of the things that they found that older patients or older teenagers are really at risk. And they're also at risk if really just an isolated complaint of pain is the only presenting symptom. Part of this provider is related to the idea that in older patients, they're being less closely watched by their parents and perhaps by their pediatricians. And I think that in teenagers also, there's a reluctance to disclose symptoms sometimes. There's also differences in tumor types and characteristics between age groups that might contribute to delays as well. So I will say that it's interesting that this study also looked at if there was any relation in time to delay between urban and rural patients, family income, type of insurance. And this study did not show that there was actually any difference in delays, but I think those other barriers to getting good healthcare are always important to keep in mind as well. A little bit more about what disease factors for the cancer itself might make it harder to diagnose. And a lot of these fall into the category of not necessarily fitting the textbook description of what symptoms you might expect, and therefore they just create more of a diagnostic mystery. And I think that that can delay time to diagnosis as well. This includes if a patient presents with symptoms such as seizures, enuresis, endocrine dysfunction, or behavioral changes. There's a lot of things that might contribute to that other than a brain tumor. Similarly, in patients who have leukemia, if they have prominent bone pain, leukemia might not be at the top of your differential. Lymphadenopathy that's subtle or a little bit waxing and waning without significant respiratory distress or abdominal mass, you might not think of lymphoma right away. Similarly, for neuroblastoma, if there's not a discrete mass, it might not be something that you're sort of primed to pick up right away. And for bone tumors, if it's intermittent symptoms or a patient has had trauma in the area, tumor is not the first thing that you would expect. But why are we trying to decrease the time to delay? All of the time to diagnosis, I think all of this comes down to really wanting to reduce acute complications. And unfortunately, a lot of these cancers can be rapidly progressive. So sometimes patients present with these symptoms, but I think ideally, if we can pick up on early clues, then patients may be able to avoid getting to a point where you're worried about herniation or cranial neuropathies. For a patient with leukemia to have hyperleukocytosis, severe anemia or hemorrhage or renal failure, and avoiding airway impingement for lymphoma, spinal cord compression for neuroblastoma, or fracture and once again spinal cord compression. So I think all of these acute complications are the things that we want to avoid if at all possible, recognizing that unfortunately in some patients, these may be the things that first bring them in for medical care. So with that, I wanted to introduce some cases, and please, if you have questions, I think in this format, we'll try to make it a little interactive, but otherwise we will certainly answer all the questions at the end. So to start off with case number 1, we have a 13-year-old boy who presented to urgent care for cough and eye puffiness. His exam was notable for bilateral lower eyelid puffiness, no redness or discharge, and he didn't have any other edema, but had some bronchi on exam. So he was, appropriately diagnosed with a viral upper respiratory infection. However, 2 days later, he came back because he had persistent cough, and now he has some dots on his eyelids and leg pain. And the exam was notable for a tight cough, these petechiae on his eyelid, and still he has some scattered bronchi and decreased breath stems at the bases. So he was diagnosed with an asthma exacerbation and given prednisone and albuterol, which provided temporary symptomatic relief. Unfortunately, 3 days later, this patient came back to the emergency room for worsening cough, especially when laying down at night. And here he appeared clinically unwell. He was anxious and he had diffuse wheezes with subcostal and intercostal retractions. So it was at this point that the emergency room got a chest x-ray, which shows this really significant anterior mediastinal mass, essentially taking up a lot of his lung volume. And Amy, I don't know if there's a way that we can make this interactive, fantastic. So for those who are able to, you can see the poll on screen, and it would be great if you enter in your response. For case number 1, what would you do in this situation? A, panic. B, put the child on oxygen and have him lay flat to minimize anxiety. C, prescribe Decadron to minimize airway swelling. Or D, call the Lucille Packard Transfer Center to arrange for critical care transport. I'll give everyone just a minute to enter in those results, and we can take a look at them. Though I will say, Amy, do you know if they have to answer all 3 before they can submit? Because I think then it might be tricky to see the choices. We can also review this at the end.
Sorry, I do not know that. Hopefully you don't. I
Okay.
to show the first one, but sorry, rookie at polls here.
No worries. Okay, so we will say that please enter in your answers, and maybe we'll review once we have all 3. For this patient, I would say panic is understandable. So you can panic a little, but really in this case, I would say please call Oncology and the LPCH Transfer Center and get this patient safely here so they can get further workup. Anterior mediastinal mass is a medical emergency. Cardiovascular effects include compression of the right atrium and ventricle, compression of the superior vena cava, and can decrease preload and cardiac output. This also leads to respiratory distress from mass compression of the trachea with the risk of sudden loss of airway. And so keep in mind that effects are worse when the patient is supine due to gravity from the tumor just compressing structures, and also under anesthesia because they have smooth muscle relaxation. So when this patient got here, they were assessed from a respiratory standpoint, and certainly prior to transportation as well. It's important to notice stridor, orthopnea, wheezing, or dizziness, and also consider, I guess, first, if you can even get imaging safely is always a question, and then assess for tamponade, SVC obstruction, and tracheal compression. And maintaining the head of the bed elevated is important, and in very significant situations, you can also consider proning the patient, because then the anterior mediastinal mass actually helps open up airways. And the most important thing is to obtain a rapid diagnosis by doing a mediastinal mass biopsy if necessary, or certainly if there are more superficial lymph nodes, we do a biopsy there, as well as a bone marrow biopsy. And usually these procedures are done awake due to the risk of anesthesia for patients who have an anterior mediastinal mass. So this patient was able to lie supine momentarily to get a CT scan where you see this very significant mass. And I think most importantly, you see that really their trachea is incredibly compressed. There's a very small opening. So definitely at risk of having a respiratory collapse if they were to be sedated at all. So fortunately, they underwent an awake biopsy. And once we have that diagnostic tissue, they can then be started on steroids, even prior to having a confirmed diagnosis, just because they're critically ill. And once they were diagnosed with T-cell lymphoblastic lymphoma, they then started on induction chemotherapy and are now doing well. So take-home points from this case are, do not prescribe steroids unless you are confident the patient does not have leukemia or lymphoma. It can just make it very hard to obtain the correct diagnosis if the patient has been pretreated with steroids. And also, if you see a patient who has swollen eyelids or a puffy face in general, consider SVC syndrome and certainly get a chest X-ray in those patients. And then really mediastinal mass is a medical emergency. We worry about orthopnea as a sign of impending loss of airway. So keep the patients upright and get them to an emergency room as soon as possible. You can always call the transfer center for help. This next case is a 16-year-old girl who noticed a lump above her clavicle. Being busy with life, she didn't see her pediatrician until 2 weeks later, where on review of symptoms, she had fatigue. She had recently broken up with her boyfriend and was not feeling great about that. She denied having any fevers, weight loss, or night sweats. but she was diagnosed with lymphadenitis and treated with antibiotics. 2 weeks later, she went back to her pediatrician because this lump was bigger. At that point, an ultrasound was obtained, which showed a 3.6 by 1.8 centimeter supraclavicular mass. And on further thought, she realized she'd actually had a decreased appetite and lost about 15 pounds over the past 6 months. And so at this point, the doctor requested a fine needle aspirate, which unfortunately did not yield diagnostic tissue. And so the patient was referred to oncology. And chest X-ray was obtained at the time. This one also has an anterior mediastinal mass, but slightly more reassuring picture than our previous case, where the mass is not taking up as much lung volume, and you can see that they have a patent trachea on the chest X-ray. They did get a chest CT, which also shows that, the trachea is well preserved. And the patient really did not report any orthopnea. So this patient then underwent an excisional biopsy and ultimately was diagnosed with Hodgkin lymphoma and was started on chemotherapy as an outpatient. And after 2 months of therapy was done and is now doing well. So I think this is our next question. If you want to fill in the cancer poll, which of the following patients would you refer for further evaluation? A 2-year-old male with 1 centimeter anterior cervical lymph node that's been present for about 1 month. He's otherwise well. A 15-year-old with a sore throat, fatigue, multiple enlarged tender anterior and posterior cervical lymph nodes for about 2 weeks. And labs are done, and he has a CBC notable for an ANC of 1,200. C, a 17-year-old male with non-tender left supraclavicular lymph node who's otherwise well. Or D, an 8-year-old female with a 1 centimeter tender left inguinal lymph node, which decreased in size but did not completely resolve 2 weeks after a course of antibiotics. I will say that we see a lot of patients with lymphadenopathy, and as long as they are clinically well, close observation with clear return precautions is completely appropriate. But there are some things that should prompt further workup for referral. So we'll review the answers to this case in a moment. Please fill in your answers. So for lymphadenopathy, the features of greater concern for cancer are large size, so over 2 centimeters. If they're non-tender or firm, I would say that really on physical exam, there is usually a significant difference in, tender URI associated cervical lymphadenopathy, even if the lymph nodes are enlarged, and the firm, hard, matted lymph nodes that we see in patients with lymphoma. Supraclavicular location is a concern. And so are associated systemic symptoms such as fever and weight loss. Certainly the fact that infection can cause fever and enlarged lymph nodes, I think always complicates the picture. But if this is persistent for over 5 days, or the fever resolves, but the lymphadenopathy does not over several weeks, that is always concerning. And then I think it's also helpful to look for associated physical findings in patients who have hepatosplenomegaly, bruises or petechiae. Those would prompt sort of further workup at that time. However, in other cases, I think, doing a trial of antibiotics and waiting for a few weeks to watch for resolution is completely appropriate. If concerned, if you are finding some of these features and want further workup, a CBC with differential, ESR, LDH, uric acid, and EBV are, I'd say, the most helpful labs to send. Certainly, mono is quite common and can produce, in addition to fevers and lymphadenopathy, some hepatosplenomegaly, fatigue, even weight loss. And so checking to see if this is an EBV infection can be helpful. I would say if you have any concerns, getting a chest X-ray is probably one of the best ways to, rule out a mediastinal mass. If they do not have a mediastinal mass, you have some time to wait and see if the lymphadenopathy will resolve on its own. However, if they do have a mediastinal mass, as with the prior case, that then sort of escalates how quickly we have to work up this patient and get a diagnosis so we can start treatment. And then I would say, depending on your level of comfort, if you are very worried about this lymphadenopathy, you can refer for excisional lymph node biopsy. If you would also want to first refer the patient to oncology for us to evaluate and then discuss whether it's appropriate to get a lymph node biopsy, that is also completely appropriate. But we would really recommend getting the excisional lymph node biopsy. In adults, they do more fine needle aspirates and core needle biopsies, but really with the goal of sort of both reducing time to diagnosis and decreasing the number of procedures patients need. The excisional lymph node biopsy is really the best way to make sure that in one procedure you get the tissue that you need to arrive at the correct diagnosis. Okay, I see a question about ordering uric acid. And so I think that is a great question. What I would say is the other thing, in addition to getting a chest x-ray and seeing a mediastinal mass, that would make me concerned that, this patient needs to be diagnosed and start treatment within the next 24 hours, would be that if you got a uric acid and saw that it was, 10 or higher. Certainly high LDH and high uric acid are much less likely to be due to, LDH is hard because it's an inflammatory marker, but if you have a patient who has an elevated uric acid, that immediately makes me very concerned this could be a lymphoma and they could be on the verge of having tumor lysis. So that's why I think it is important to get, because it's one of the things that would make you, very rapidly want to get the diagnosis. And then there's another question about if a child has persistent lymph nodes less than 2 centimeters or right around 2 centimeters, but mobile and soft, what would you do? Yes, that is absolutely a common issue that we see. And I think that that sort of goes back to, if they're right around 2 centimeters, the patient is otherwise well, or there's no like clear infection going on. I think close monitoring, if they have decreased in size in a month, that is reassuring. Certainly, if they are persistent, I think at least getting a chest x-ray and labs to make sure there's no lab abnormalities would be good. Unfortunately, I will say with lymphoma, you can have normal labs and still have disease. But I think, if you have slightly enlarged lymph nodes in an otherwise well child and they're mobile and soft, you really can watch them over time and hope they resolve. If it seems like they are staying stable in size and, the family is anxious, you can always refer them to oncology. There are intermediate things that we can do, like getting a ultrasound of the lymph nodes, though I will say ultrasound, other than sort of providing a concrete measurement of the lymph nodes, and in rare cases, if they see anatomic changes to the lymph nodes, usually does not tell us much, but I think can be something to do. But absolutely, I know having enlarged lymph nodes and what to do with them are a very common question. But I think that, you really can see what happens over time, because the vast majority of them should improve. And then the next question is about getting a CT scan. I will say that, if there is a concern for lymphoma, unfortunately, no amount of imaging, MRI or PET scan or CT is going to, rule out lymphoma. It's really doing a biopsy that will. So I think if you have enlarged lymph nodes that are firm and hard, and any concerns, the biopsy is really the step that's going to give you the answer, not the CT. I will say that probably some ENTs or surgeons would want to get cross-sectional imaging for the biopsy, but if it's a sort of superficial lymph node, they should be okay going ahead with the biopsy. I already sort of addressed the ultrasound question. I think kind of like the imaging, they can be helpful, but it never really completely rules in or out something. But I think if you're just wanting to monitor the size over time, they can play a role in that. Okay. So I knew lymphadenopathy is very common. So happy to answer more questions about that. But for this case, we will move on to our next case, which is a 4-year-old girl who presents to urgent care for fever of 3 days and sore throat. She is rapid strep negative, diagnosed with viral pharyngitis, and sent home with supportive care instructions. Unfortunately, 3 days later, she was taken to the emergency room for persistent fevers, throat pain, is spitting up saliva, and not wanting to walk. So at this point, I think the differential is wide open, but if people wanted to fill out our survey about whether you would A, you're concerned about abscess, get more neck imaging, B, this is still clearly viral pharyngitis, let's continue supportive care, C, in fact, this sounds more like infectious mononucleosis, let's try some Decadron for throat pain, or D, she's now had 6 days of persistent fevers, this could be concerning for leukemia, let's check labs. Great. And then I will say, now that we've answered all 3 questions, Amy, if there is a way to bring up poll results, we can try to show them. Otherwise, we may abandon polls. But thank you, people, for active participation.
I'll give people one. It seems like a few people are still answering. Give it another few seconds, and then I think I can end it.
And I will say, especially for this one, I think there are multiple things that, fall into the category of appropriate care. Great. So let us quickly review all of the cases. For case number 1, our patient with the really large anterior mediastinal mass, most of you chose to call the transfer center, which I think is great. In terms of supplemental oxygen, I think that can be completely appropriate. It is really the laying flat in B that I would avoid. And similarly, if the patient is in impending respiratory collapse, by all means, use steroids, do what you need to do to stabilize the patient. But if they are okay, it's best to hold off on giving Decadron until we at least have a tissue biopsy so that we can make sure we have the right diagnosis. For case number 2, yes. So once again, I think there's always a little bit of question about what to do with these lymph nodes, and every case is a little bit different. From my standpoint, I would say C is the correct answer. Really, a non-tender lymph node is more concerning to me than a tender lymph node. And the supraclavicular location, more so than cervical, is concerning for malignancy other than being reactive. I will say for the patient in B, certainly they have a lot of symptoms that are concerning, as well as a slightly low neutrophil count. The one thing I would say about B is this might be a patient who really sounds like this could be a viral infection with tender nodes, and viruses can also cause some neutropenia. And so, maybe a little more watchful waiting could be beneficial, but certainly if there are any concerns, refer to oncology. And then for D, the patient who has a inguinal lymph node that is decreased in size but has not completely gone away after antibiotics. I think the fact that it decreased in size is what's reassuring, and it might take a little bit more time for it to completely go away. But if the lymph node seems like it's, for the most part resolving, a little bit more watchful waiting is probably appropriate. For our case number 3, and once again, these are kind of leading questions. I think, having concern for an abscess in this patient is appropriate. And so I think in the emergency room with the child spitting up saliva, more imaging is appropriate. Similar concerns about infectious mononucleosis. I think if the patient was in impending respiratory distress, then you could consider Decadron. But as long as leukemia or lymphoma is on the differential, I would really encourage you to try to do a little bit more workup to rule that out before giving steroids, which we'll talk about more in a second. And then once again, since this is a talk on pediatric cancers, there is a concern for leukemia. And so I think in this patient who's had, over 5 days of persistent fever and other symptoms, I would get a CBC at this point. However, that ED just thought, oh, this is still viral pharyngitis, and sent the patient home. So they then, and with some lidocaine, but then 3 days later, they showed up back to a different ED with persistent fevers, now weight loss and gum bleeding. There, they got a CBC that showed a white count of 4, a hemoglobin of 3.8, and platelets of 28. Of note, there were no blasts on the differential. So the patient was admitted to the PICU due to severe anemia and was given a slow transfusion of blood and platelets. But for workup of the anemia, they got a bone marrow aspirate, which showed a diagnosis of pre-B-cell acute lymphoblastic leukemia. So a few things to talk about in this case. So signs of symptoms of leukemia can be very tricky to pick up on since they overlap with many common childhood illnesses and normal findings like bruising. So I would always ask about bone pain, fatigue, pallor, anorexia, and mucous membrane bleeding with toothbrushing. I think bone pain in particular, and this patient had some refusal to walk, that is a red flag, especially if in the setting of these other symptoms, even if the complete blood count looks okay. And then on exam, certainly watch out for petechiae, pallor, lymphadenopathy, and plattosplenomegaly. And so I'd say most often when we get a complete blood count, and this patient has leukemia, we will see blasts or others, or some review of the peripheral smear will show up cells that look atypical. However, having 2 cell lines down is also a big red flag. This patient's white blood cell count, was actually normal, but it was really the hemoglobin and platelets being down that was of concern. And so, we see patients who come in with white counts over 100, and we see patients come in with white counts of 1 or less at diagnosis, but they can also be normal. So if you have any concerns about findings on the CBC, you can always refer to oncology, but I would say if there are 2 cell lines down, that is a definite referral for further workup. Anemia with a high MCV is also of concern because that patient may have a myelodysplastic syndrome. And then once again, there are some rare cases where the CBC may be normal, but if you have other symptoms and signs that just altogether make you suspicious for leukemia or malignancy, that is, a good person to referral to oncology as well. So going back to this case, did the delay matter in her care? I think for the family, all of the back and forth, needing to repeatedly go to the emergency room led to some loss of confidence in the healthcare system. But then also specifically for our leukemia patients, pre-treatment with steroids automatically upgrades their risk from, if she would have been standard risk, she's now high risk due to that pre-treatment. And that means that she will get more intense treatment. And due to that intense treatment, she is both at risk for sort of acute side effects and long-term sequelae, including a higher risk of infertility and secondary cancers. And so that's really, why, please, if you are concerned that leukemia or lymphoma may be on the differential, at least stop and try to rule those things out before giving patients Decadron. And once again, not meaning that you have to do extensive workup, but at least always think through if it is a potential concern for any given patient. So the take-home points, any fever more than 5 days should prompt a more thorough evaluation. Ask about weight loss, bone pain, pallor, and easy bleeding. And once again, I feel like one of the takeaways from this lecture is sort of think twice before prescribing steroids. They absolutely are helpful in managing a lot of things, but they can obscure the diagnosis and even upstage patients with leukemia.
Before we go to the next case, there's a couple questions in the chat, if you don't mind.
Absolutely. Okay, I'm just going to read this off. I often think of fevers with malignancy as being more chronic rather than acute. Can you help us to understand which characteristics of malignant fevers might make us more worried? We see courses of fever 3 to 6 days all the time, and it's hard to know when to consider malignancy in that setting. Perfect. Yes, I will say that if it is a fever going on for weeks, then, I think that prompts a whole bunch of workup, like could they have some kind of rheumatologic condition or infection. But from an oncology standpoint, it really depends ultimately on what their underlying oncology diagnosis is. If this is a slow growing lymphoma, it might be that they've had fever for 3 weeks. However, if it's fast growing, or if it's an acute leukemia and over the course of a week, they go from being healthy to, having these CBC changes, then I think it can be a much shorter fever. And so that's why, from our standpoint, we really say after fever of 5 days, then I would at least consider checking a CBC, because once again, that might, I think more often than not, likely that patient just has an infection and you will see a normal CBC, but you might help pick up earlier patients who have leukemia, who otherwise would need to wait another week before they come to attention. And so really, I would advocate for if it's a week of fever, at least check labs to make sure that you're not missing something. But I also understand that for families, getting labs, all of that is hard, but definitely sort of our cutoff for being concerned is around anything 5 to 7 days of fever. We at least want to make sure that we're not missing something. Please clarify 2 cell lines down. Essentially, the different cell lines that we look at are the white blood cells, the hemoglobin, and the platelets. And so if you have white blood cells are 1 and platelets are 20, that makes me concerned that there is an acute process going on in the bone marrow. There, could be other reasons, but definitely always want to consider that there is something wrong in the bone marrow if you see more than 1 cell line down. Certainly you could have white blood cells and hemoglobin down and platelets are normal, or any combination, or all 3 cell lines down, but 2 or more makes me worried about something happening in the bone marrow. Would a short course of oral steroids change the staging? So for lymphoma, no, other than I think the 2 things are, other than perhaps, and I'd say this is more of a theoretical concern, that steroids would really obscure the diagnosis, with the idea being that lymphomas are so steroid sensitive that if you gave steroids, the lymphoma would melt away and we wouldn't be able to pick it up on biopsy. I've really never seen that happen. But in leukemia, even a short course of oral steroids is going to upstage that patient to be considered high risk, just because similar concerns that they might have had cerebral spinal fluid involved with leukemia, but by taking steroids, we were treating that. And so we always sort of treat them as if they are the highest stage if they've gotten that oral steroid course first, just because sort of the risk of not treating them to the full extent and having them relapse is higher. Okay. Another common issue is that we consider growing pains, typically if bilateral, occurring mostly at night. Yes, exactly. So I think that growing pains are hard, and much more common to see that. I think if someone has pain in their legs and fatigue or petechiae or any of the other symptoms, then I would consider checking labs at that point. But yes, I think that if it is unilateral, and we'll get if it is unilateral persistent, if you're worried that there could be something going on in the bone, you could get x-rays. You can actually diagnose leukemia from x-rays. They develop leukemic lines, which just shows bone marrow involvement, or consider getting a CBC. So I think absolutely, growing pains are much, much more common, but if you see leg pain and any other symptom, then consider it. And then, sorry, if someone could clarify the question, why fast bleeding? I'm not sure I understand. And then resources for pediatricians to learn more about CBC differential interpretation. I will try to find some because I do think that understanding the differential can be helpful. Certainly, the main thing that we look out for is neutropenia when your neutrophils are down. And then with treatment, we see other changes. But I think understanding sort of the other changes that we've seen are helpful. So I will get back to you on that. Now
Maybe
moving
we could do
on.
another webinar.
Yes, I'm going to move on to our next question, or next case, a 15-year-old who's seen by his pediatrician for a few weeks of back pain. His exam is benign, and so he's diagnosed with muscle strain. But a month later, nothing's gotten better. So he comes back and is treated with some NSAIDs, still not getting better. So he's prescribed muscle relaxants. So ultimately shows up in the ED after 2 months of back pain, and now he's developed a cough and weight loss. So in the ED, they get a chest X-ray due to this persistent cough, and they actually find extensive hilar and peritracheal lymphadenopathy. And so they quickly get a chest CT abdomen pelvis, which shows lymphadenopathy throughout his chest and abdomen. And so he's sent to oncology. And they think he's, one of our earlier cases, and this is lymphoma. However, not in the ED, but once he reaches the oncology floor, they actually do a full head-to-toe exam and see that, in fact, this patient has an 8 by 14 centimeter testicular mass. So at that point, he gets an orchiectomy and is diagnosed with a mixed malignant germ cell tumor. And over time, starts chemotherapy and also undergoes 5 operations to remove metastases from the neck, chest, and abdomen. So I wish I could say that this is an isolated incident where this teenage boy did not report a giant testicular mass, and the ED, did a thorough exam and didn't miss it, but this actually happens relatively frequently. And so for this patient, did delay matter? One of our oncologists, Dr. Sherry Spunt, actually specifically looked at this issue and reviewed cases of 49 patients who were treated for testicular germ cell tumors. The time from symptoms to diagnosis ranged from 1 day to 447 days, with a median of 52 days, and longer time from symptoms to diagnosis correlated with larger tumor volume, higher stage disease, and inferior survival. And for patients over 10, they had longer time to diagnosis than younger patients and were more likely to have higher stage disease. So take-home points from this case: adolescents often avoid mentioning these painless testicular masses, even when they're quite large. So ask. Back pain due to retroperitoneal lymph node metastases is among the most common presentations of testicular cancers. So careful genital and neurologic exam will uncover most causes of back pain, most oncologic causes of back pain. And I think as pediatricians, it is really important to coach boys on the importance of reporting changes in their testicles to a provider or family member, because they otherwise don't want to tell you. I'm going to move a little quickly to make sure we cover all of these cases, and I'll answer questions at the end. Case number 5 is a 7-year-old boy who was brought to his pediatrician for headaches, abdominal pain, and school avoidance. He really didn't want to go to school and was having these complaints, and the teachers reported he was having difficulty focusing and covering his right eye when he looked at the board. So he was referred for an IEP and optometry. He then came back 2 weeks later for intermittent fevers, cough, and persistent headaches, had a normal exam, but his chest x-ray showed pneumonia, and so he was treated with azithromycin. And 2 days later, he went back to the ED with fatigue, and really was not acting normal at this point. So he was admitted to the hospital to start on cefotaxime and azithromycin for his pneumonia, but on the second day was found unresponsive with a fixed dilated right pupil. At that point, he got brain scans which showed a right temporal parietal mass, and after surgical resection, was diagnosed with glioblastoma multiforme. So I think headaches are another, like lymphadenopathy, are one of those things that have a lot of causes, most of which are not malignant, but definitely if you have persistent headaches, that is of concern, especially if they are combined with these other findings, such as vomiting, ataxia, seizures, hemiparesis and facial weakness, visual loss, diplopia or other gaze changes, swallowing difficulty, slurred speech, certainly macrocephaly, weight gain or loss, polydipsia, developmental delay, school performance or behavior changes. So I think this is another issue where as pediatricians, you have to sort of go through all of the many different causes of headaches and make sure that you don't miss ones that could potentially be due to brain tumor. So a few of the things that might prompt you to get head imaging or referral sooner are unusual symptoms such as photophobia or covering one eye. If patients have had weight loss of no clear etiology, and then just the reminder that as with this case, you can have two medical problems that coexist, like pneumonia and this brain tumor. We're always looking for that unifying diagnosis, but it's possible that there could be two different things going on. Case number 6, a 17-month-old girl is evaluated by her pediatrician for a right lazy eye and diagnosed with strabismus with no further evaluation. However, 4 months later, she's taken to an optometrist because her right pupil looks abnormal, and the optometrist sees leukocoria and refers the child to an ophthalmologist. Ultimately, this child gets a brain MRI that shows that she has retinoblastoma, and so has to have a right globe enucleation because there's no potential for recovery of vision due to the size of the retinoblastoma. And so she has to face these lifelong issues. I will say, fortunately, if the entire tumor can be removed, then she would not need chemotherapy. If it has advanced further, then chemotherapy may be indicated as well. And this is just a reminder, as I'm sure people are doing, to check the red reflex. And if there are any changes, prompt referral to an ophthalmologist is important to try to catch this as early as possible. And similarly, any child with strabismus beyond 4 to 6 months of age should be evaluated by an ophthalmologist. Okay, last case, bear with me a few minutes longer. A 3-year-old girl with a history of chronic constipation presents with palpable abdominal mass. She's also noted to be hypertensive. So due to her history of constipation, they sort of increased the Miralax dose until she's having clear stools. However, a few days later, she has clear stools, but the mass is still present. And so an abdominal ultrasound is obtained, which shows a large left-sided abdominal mass, but unclear where it's coming from. So the differential diagnosis of abdominal mass is long, and it can be helpful to think through anatomical location based on the mass and what might be the underlying cause. The age of the patient also impacts the likelihood of certain malignancies. In this 3-year-old age group, sort of neuroblastoma, Wilms tumor, hepatoblastoma are the top of the list, but it's slightly different in older children. And then, of course, there's a lot of non-malignant causes of abdominal masses as well, but certainly if you have an abdominal mass that does not seem to be improving, further imaging is warranted. And in this case, the patient got an MRI that showed a giant left-sided renal tumor. So she was referred to oncology and underwent a left radical nephrectomy, which confirmed the diagnosis of Wilms tumor. On chest CT, which we get to evaluate for any lung metastasis, that was negative. So they then started on chemotherapy and are doing well. But just for abdominal masses, really, if you have a massive concern, get further imaging and think about where that abdominal mass is when coming up with your differential diagnosis. And then Wilms tumor is a good segue into the next slide, which is about predisposition syndromes for cancer. Essentially, we now believe that about 10% of pediatric cancers are associated with inherited mutations. Previously, the number was lower, but actually, as we've been doing more and more genetic testing of patients, we actually find mutations that are inherited and likely contributed to their risk of getting cancer. And therefore, people have worked to develop screening guidelines for surveillance of patients who have a known genetic predisposition along the lines of this entire talk, where especially in patients who we think are at high risk of developing malignancy, if we can potentially catch a diagnosis earlier, that can then help with treatment and outcomes. And so if you are concerned about a genetic predisposition syndrome based on family history of a patient or physical exam findings, I would really recommend referral to medical genetics to sort of define the predisposition syndrome, and then also to pediatric oncology, who can help with the screening guidelines. I think partnering with pediatricians can be really helpful in these cases. Oftentimes it's just getting an ultrasound every 6 months, or depending on the situation and what exactly the cancers we're looking for are. But I would say, although I would want to do this in partnership with the pediatric oncologist, pediatricians can be very helpful in monitoring these patients as well. Lastly, very quickly to just summarize the oncologic emergencies, I feel like we've touched on them with varying cases, but certainly if you have a patient who is presenting acutely ill, hopefully not in your outpatient clinic, but you never know, it's always helpful to sort of have in mind the different problems that might arise that could be due to cancer, so that you think of what workup and support would be necessary. So for the ABCs of oncologic emergencies, for airway, you can have compression, often due to superior mediastinal syndrome and large anterior mediastinal masses. Similarly, those can cause pulmonary effusions that cause breathing problems, also cause SVC syndrome, tamponade, or arrhythmias. For C, circulation. For D, disability, you can have masses that are impinging on the spinal cord, causing pain and paralysis. Anything that has high cell turnover, such as lymphomas, you can get tumor lysis syndrome, which then can cause a lot of electrolyte abnormalities. Those can similarly, either due to electrolyte changes or mass compression, cause F, failing organs. Or from a GI standpoint, you can get obstruction, intussusception, bleeding, perforation, or jaundice. Back to thinking of our leukemia patient, when you have low platelets, you are at risk for thrombocytopenia and hemorrhage. Many of these things, if they are involving the liver, could also lead to coagulopathy. And then sort of going back to the question of fevers, hopefully patients wouldn't be presenting with prolonged neutropenia. It's likely something they developed more acutely, but I think there's always the risk that the fever could be due to an infection, but an infection that they got because they have bone marrow suppression and leukemia. So this is a somewhat helpful mnemonic to put together all of the many ways these can be scary patients to manage, but we are always available to help. Please, if you have any concerns, whether it is an urgent, emergent concern or a routine question, even, should I refer this patient? Would it be helpful for them to see oncology? Please reach out. We are always happy to discuss and help support the families and you in taking care of these challenging cases. So just a summary of when to think about childhood cancer. When you see that abnormal blood count on the CBC, if you have a patient who is tired, especially if they have new lymphadenopathy and or hepatosplenomegaly, if they have bone pain that's persistent, requiring analgesia, limiting activities and not getting better. We discussed lymphadenopathy, but yes, give them some time. But if they have one of these things, and things are not improving, then I would definitely do more workup. And similarly for headaches, if they are increasing in severity or frequency, worse in the morning, or cause early awakening, causing vomiting or neurologic signs, or if you have an acute behavior change or deterioration in school performance. And for a soft tissue mass, if it is rapidly growing over 3 centimeters or fixed or deep to fascia, those are all reasons to please refer to oncology and get further workup. Thank you for your attention. Let me see if there are more. Okay. I'm going to try to answer these questions. Can you please elaborate on more details to look out for with persistent headaches? I think it's true for headaches that time range can be a challenge, because certainly if people have migraines or other things that they could have headaches that are going to become chronic. I think the big thing for persistent headaches is, if it doesn't seem like it is a migraine, if they have any of the other symptoms, really I would use the other symptoms as the main trigger to get further imaging. But I think if there is concern and you have someone who's been having a headache for, 2 to 3 months, that is every day, limiting their activity, that is definitely someone who should be referred to neurology. I will say, I don't think you have to jump straight to brain imaging or oncology, but just if it is headaches that, are not getting better, further imaging may be warranted. And I think neurology is also helpful in those cases. Best imaging for initial concerning abdominal pass after X-ray. So good question of CT versus MRI. I think for most cases, CT scans will probably tell you what you want to know. MRI does have better imaging quality, but I think depending on the age of the patient, like whether or not they need anesthesia, CT scans usually will get you the necessary information. There may be cases that ultimately they end up, if they were to have an oncologic diagnosis, end up getting an MRI as well for like pre-surgical planning. But I think CT scan usually would be an appropriate place to start and just easier to get from a logistics standpoint as well. Is early morning headache specific to cancer? I will say sort of textbook answer is yes, with the idea that if you have an intracranial mass that is going to just put you more at risk sort of when you're going from a laying down to sitting up in the morning of having early morning headaches. And certainly vomiting may be a part of that too. So I would say that that is one of those concerning symptoms, not to say that brain tumors couldn't cause headaches at all times of day, but if it is a patient who's having early morning headaches, that is a symptom that would make me try to get additional workup sooner rather than later. Any other questions? I think we're almost right at time. So thank you so much for your attention.